Hi, and welcome to the Supporting Functional Mobility and Safe Transfers training. This is the online portion of the training that you'll complete independently before completing an in-person skills portion. I'm Andrea, one of the occupational therapists at Cheers, and throughout this training you'll hear from me and OT Cove. Please take a moment now to pause and complete the pre-training knowledge check if you have not already done so. Let's define functional mobility. This means moving from one position to another to do an activity. We all use functional mobility in our daily lives when we get in and out of bed, in and out of the shower, when we walk around with or without a mobility device, and for wheelchair users, navigating the use of a wheelchair to get around as well. At Cheers, we all play an essential role in helping clients to move around in their daily lives. This virtual training today has three main sections: transfers, wheelchairs and mobility devices, and falls. The online training provides the foundational knowledge you need in each of these three areas to then go on and complete the in-person skills portion. The skills correspond to each of these sections and will include a bathroom transfer scenario, an equipment showcase and maintenance check, and case discussions. There are 8 main learning outcomes. The first is understanding the RF and CF role as well as the OT role in supporting functional mobility and safe transfers for individuals with ABI. Second is understanding the relevant policies and legislation that guide our roles and responsibilities. Third is learning and practicing strategies to support transfers in various settings. Fourth is discussing posture and body mechanics principles to prevent injury. Fifth is learning the procedure for getting up from a fall with and without hemiparesis. Sixth is identifying the key features of mobility devices and how to maintain them. Seventh is understanding strategies to support community mobility. And eighth is reviewing and becoming comfortable with a variety of transfer and mobility tools. This training is taken every 2 years to protect you from injury, increase client safety, and ensure we're adhering to legislation and policies for a safe workplace. As part of our introduction, let's look at which policies and laws guide us as we support clients' transfers and functional mobility. The Workplace Health and Safety Act is a law that outlines the roles of the employer, supervisors, and workers regarding safety in the workplace. So when your role involves supporting clients, there is a potential for injury. So the employer is required to provide training, such as this one, and the necessary equipment so that you can do your job safely. For example, PPE. As a result, employees are required to comply with trainings and policies and to use the necessary safety equipment. Employees have the right to refuse unsafe work. Unsafe work should be reported to your supervisor and a member of the Joint Occupational Health and Safety Committee immediately. And as part of this Health and Safety Act, as I mentioned, Cheers needs to have policies in place. So let's look at the policies that are relevant to supporting clients with their transfers and functional mobility. I'll draw your attention to 4 Cheers policies and guidelines that help us understand safe work practices to support clients, respond to falls, and reduce the chance of getting injured yourself. The first is Policy 5.18, Supporting Functional Mobility and Safe Transfers, where this training gets its name from. And this policy outlines general safe work practices, responsibilities, and procedures when you're supporting clients' transfers, repositioning, and responding to clients' falls. There's also a support guideline called Managing Transfers, Repositioning, and Falls, and this really helps to provide guidelines that facilitate everyone's safety while promoting independence and ensuring that the way that we're supporting clients is consistent. And as part of this, clients have individualized support procedures. The next support guideline is the Fall Prevention Program. This lets everyone know what Cheers' strategy is to prevent client falls and fall-related injuries. And finally, 5.25, the policy on preventing and managing musculoskeletal disorders. This is to increase employee awareness and knowledge about musculoskeletal disorders and safe work practices in place to reduce the risk of these disorders. This is really important as a staff member, and it would have been part of your initial onboarding, but you can always refer back to these policies and guidelines on SharePoint. So now that we've been introduced to what functional mobility is and some of the legislation and policies at Cheers that guide us, let's think more about, our specific context that we work in and think about how can brain injury impact a person's ability to move around safely. This information informs how we approach what we do in supporting clients. So first, let's think about the physical impacts of brain injury. Brain injury can disrupt balance by damaging areas of the brain that control coordination, sensory processing, and movement. And because balance depends on multiple of these brain systems working together, brain injury can increase fall risk and make it difficult to move around steadily. So what might you notice? Well, a client might experience unsteadiness when they walk. They may have stiff, jerky movements, or they might walk at a faster or slower pace. What are some strategies that could help with this? Well, for example, the gentleman in this image uses a cane, and mobility devices like canes, walkers, and wheelchairs are often recommendations by occupational therapists. This person on the right is reaching up for a high shelf, and it looks like they could stumble or fall backwards. We also do see this with clients who have balance impairment, and so in this case, we might think about how can we reorganize the environment and the task that they're doing in order to reduce the risk of falls. So we'll take a look at more of what we do later, but just keep in mind that it's important to be aware that brain injury can impact balance, coordination, motor planning, and all these sensory aspects that help people to move around safely. And so knowing your role as a CF and RF to support them, it's important to know how they would use their mobility devices or how we would follow support procedures. Next are the cognitive and behavioral impacts of brain injury, which can result after damage to brain regions and the connections between them for higher level cognitive processes like thinking, memory, emotion, and self-control, especially in the frontal and temporal lobes of the brain. So what might you notice? Well, a client might have difficulty remembering to complete each step in a task or to initiate tasks. They might have difficulty orienting to the date and time and require support to manage their schedules. They might have difficulty maintaining their attention and they might make impulsive decisions, for example. So in the image here on the left with the person on the stool, this is a situation that is high risk of a person falling, using a stool and precariously balancing as they try and reach for something on a shelf. Whereas a safer decision would be to ask someone for help or to use a step ladder, something that's actually intended to safely support someone using this. So if a step ladder was appropriate for this person, that's what they should use instead. Another example, and something we tend to see sometimes, is on the right here you see a bathroom setup that is equipped with grab bars and a shower chair. It's meant to support a person that has difficulty with balance. But sometimes we see, instead of using the supports that are in place, a person might still lean on the wall and their hand might slip against the wet wall. We also sometimes see clients reach up for the shower rod instead of using the grab bar. And the shower rod's not graded to support a person's body weight. So in addition to the physical impacts we saw, keeping the cognitive and behavioral in mind as we start to think about our role in supporting client safety. And then there are the emotional and psychological impacts of brain injury, which can contribute to a cycle of falling and decreased mobility through avoidance behaviors. So, for example, a person experiencing depression might avoid doing things like leaving the house or taking showers. And this results in overall inactivity, which leads to lower strength and endurance for activities. And because of this lower activity and this kind of overall maybe deconditioning or weakening, this leads a person to be at increased risk of falls. So once a person has sustained a fall, they're also at a higher risk of falls due to a fear of falling, or again kind of avoiding doing things that could lead to falls. So it's important for us to be aware of clients' emotional states and aware of how much are they engaging, or is there a lot of avoidance going on, because we know that this can lead to falls and injury. So now we have a clear picture of the physical, emotional, cognitive, and behavioral impacts of ABI on safe mobility and overall well-being. These factors are all interconnected, so it's not just enough that we focus on one of them without considering the others. Our roles are to identify, what a client's individual needs are and develop those individualized support procedures and then continue to implement those supports. Because, as we looked at, the environmental supports might be in place, but clients often need continued support, at least for the first little while, to learn to use those supports and develop new habits that are safer. So overall, the more we know about how clients' brain injuries affect them, the better we can plan to support them while keeping their right to dignity and choice. Later on, we'll talk about the external factors, as these factors to ABI are internal, they're about the person, but we'll also look at things about our environment and what we're doing that can lead to falls as well. So how do we identify clients' needs and develop those individualized supports? Cheers has a clinical model with 4 pillars that organizes all the elements in the work that we do. It's a helpful way to visualize how things are done, and let's see how this relates to client mobility and transfers. The first pillar here in blue is understanding and enhancing needs and abilities. This involves the completion of assessments by the clinical team, for example, behavior therapy assessments, neuropsych, occupational therapy, and social work assessments. The results of these assessments help to determine services that clients are provided with. The next pillar is collaborative and integrated goal setting and care planning. So this involves members within the Cheers team, such as the clinical team, RFs, CFs, and service coordinators, along with the client, their family, and coordinating with external care providers. As we know, clients are not only coming into Cheers with the effects of their ABIs, but also they're living with other health conditions. And so it's really important that we coordinate that care for the best outcomes. So in the RF and CF role, you play an integral role in helping clients to remember and attend appointments, process the information that's received there, and follow up on any action items. It's a really important role. The next pillar is providing a safe and supportive environment. So not only what we're doing, but how we're doing it, how we treat one another and clients to establish a psychologically safe place. In addition to implementing health and safety procedures and helping clients with their positive everyday routines. And last but not least is meaningful engagement. This, is an integral part of what we do. It's connecting clients with meaningful activities, to decrease boredom and increase a sense of purpose, within Cheers and out in the broader community. This helps to keep clients active. And as we just talked about, staying active is a way to decrease risk of falls and overall deconditioning. So overall, we've just reviewed the Cheers clinical model. I'll now turn it over to Cove to begin our section on transfers.
In this section, we will be talking about transfers. Each of us completes many transfers every day in our own lives. For example, getting out of bed in the morning is a transfer from laying in the bed to standing on the floor. However, for clients who have ABI, they may have impairments which impact their abilities to transfer safely. Let's talk more about different types of transfers. A transfer is defined as a movement from one surface to another. Common transfers include using the toilet, shower, or bathtub, getting in and out of a car, on and off from the couch, or any type of seat including wheelchairs. At Cheers, you may assist clients to transfer by setting up the environment and providing cues for safety. Cheers clients must be able to weight bear through their legs or arms and can use adaptive equipment to support their transfers, such as a Saska pole or grab bars. Your client support procedures will include what kind of assistance they need for transfers. Finally, please remember that staff do not lift clients or take on full weight bearing during transfers. Repositioning is defined as moving to a new position on the same surface. For example, when we shift in bed from our back to our side, that is considered repositioning. If clients need help repositioning, this may include the use of equipment such as a bed rail to get into an upright position on the bed. Again, their specific needs will be in their support procedure, so please read and follow the client support procedure. Setting up transfers involve more than just physical steps. It is important that clients are active participants in transfers and not just passive observers. So you need to always communicate to your clients so that they are aware and understand what they're about to do during a transfer. For example, use phrases like ready, set, stand, and step instead of 1, 2, 3. Use alternate ways like modeling or pictures as necessary. Elicit language from the client if possible, demonstrating they understand. Or use a combination of these strategies to ensure safe transfers. Now we are going to demonstrate the steps of setting up a safe transfer using the example transferring from a wheelchair to a chair. Please keep in mind that these steps can be applied to other transfer situations like the toilet, bed, etc. Starting with step 1, ensure the client is as close to the transfer surface as possible by positioning the client at an angle. This helps decrease the distance between the transfer surfaces. Then in step 2, remove the footrest to prevent tripping. Ensure the brakes are on and then remove the client's seatbelt. Ensure client's feet are back and flat on the floor. Then proceed with step 6 and have client lead or scoot forward on their seat. Then have the client reach up high for a pull or push off their armrests. Then prompt the client to stand up. Prompt the client to step and turn, step and turn, step and turn, and finally ask them to slowly sit down. Depending on the client, some may be able to do these steps independently, while others may need verbal cues, physical assistance with removing the brakes. So what is your role as RFs and CFs in transfers? Staff can assist the client by setting up support and ensuring the environment is safe, there are no hazards, and the client has what they need before performing a transfer. For example, this may include staff removing the footrest off a client's wheelchair. Depending on the client's support procedure, you may need to present or provide supervision and verbal prompts during the transfer. There are also times where you may need to provide light touch cueing to provide activation to an area, such as tapping the right arm of a client to draw more attention to it. If you have any concerns regarding a client's transfer or mobility, please notify your service coordinator and refer to an OT. Examples include clients need more environmental supports to perform a transfer safely in their bedroom, or there are maintenance issues with the client's current mobility device and the client is due for a new one. The occupational therapist role, on the other hand, is to perform assessments for client transfers and mobility, determine how much support and prompting a client needs, and provide recommendations for equipment. Typically, you may know your clients well and have an established support procedure for transfers. However, there will be times where you will need to conduct a pre-transfer assessment to assess the client's ability or readiness to transfer. For example, you suspect a client may not be ready to transfer safely due to a recent fall, physical decline, or you suspect a change in the client's cognition from their baseline. You can use the 4+1 pre-transfer assessment tool to determine if a client is ready to transfer safely. The 4+1 pre-transfer assessment was developed by UHN and it assesses 5 factors, 4 physical, 1 cognitive, to determine a client's transfer readiness. Let's go through each factor of the 4+1 pre-transfer assessment. Before initiating a transfer, have the client perform the following 4 steps. First, for core or trunk control, have your client sit at edge of bed unsupported or sit forward from the back of their chair. Second, test the client's leg extension by asking them to extend at least one leg off the bed and/or strain one leg from the knee while sitting. Third, test their arm strength by asking them to use their arm to assist with repositioning themselves. 4. Bridging. Ask your client to lift their pelvis off the bed or weight shift side to side and front to back in their chair. Assess cognition throughout. Have they followed your instructions? Do they understand what you're saying? Consider pain and medication changes too. If you're in doubt, err on the side of caution and don't proceed with the transfer if it's not immediately necessary. So what if you perform the 4+1 assessment with your client and it doesn't go well? What you should do in this case is consider the following factors. Are you seeing a change from their typical behavior and abilities? Are they in pain? Are they tired? Or are they groggy due to a recent medication change? More importantly, is the transfer necessary? If not, then don't do it. You can also reassess a person's transfer again at a later time. Also, communicate your outcomes and observations with your team and client's family if you're unsure or if there is a significant change in their transfers. Staff can also call the non-emergency line to receive help if a client is unable to transfer.
So now let's talk about transfers in the context where they commonly occur and where your supports can take place. So the first is bathroom transfers. What is your role? Well, first, because of your direct supports, you might be more likely to notice when a client is struggling or if there's been a change in how they're transferring. So for example, what you might notice is that a client getting on and off the toilet, it looks really effortful. They might be trying to reach for things like the counter nearby or the wall to help them. And they might look quite unsteady when getting in and out of the shower. In that case, you'd want to talk to your service coordinator and consult OT for an assessment. Now let's say a client does have an equipment in place, like a grab bar, shower chair. Your role includes, monitoring that the setup is still appropriate. So for example, the shower chair is facing the shower head, not away from it. And looking out for the status of the equipment. So, are the legs wobbly? Does it look like it's starting to rust or fall apart? In that case, we might need to consider replacement or repair. An integral part of your role is providing cognitive compensatory supports through verbal and physical cueing, demonstrating and reviewing steps with clients. We'll take a look at this next. And lastly, scanning for environmental hazards. So looking for things like clutter that clients could trip over, loose tiles, or things like towels on the floor, which can be slippery and shift around. So here's an example of a support procedure for clients' showers. In this example, the client can shower independently, but requires support for setup, queuing, and having staff nearby in case assistance is needed. Other clients might have external personal attendants that provide hands-on shower support, but this is what your role looks like. So on the left column is the steps that the client would do, and again, if this type of shower support is new for the client, going through it with them the first several times with more intensive supports for demonstrating and queuing, and then gradually reducing those supports. But in general, this is what the staff assistance looks like. So first, orienting client to their schedule, reminding them it's a shower day. So a script could be, today's your shower day, I'll be back to meet you at 11 so you can shower before lunch. Next, the staff would ensure the client has the necessary shower items and clean clothes, especially if it's a shared shower space and their items are not always in there. Next, staff, again, assessing the bathroom environment for safety and ensuring equipment is in good condition and set up appropriately. And then really importantly, as we've talked about already, just because equipment is there doesn't mean the clients will remember to use them reliably. So doing things like a very simple cue. Remember to hold the grab bar as you get in and out, just like you did last time, incorporating encouragement in there as well. So this is just an example of what a real-life bathroom setup might look like. You have grab bars here, removable shower head, and you have a bath transfer board. It's just similar to a transfer bench, just it doesn't stick out of the tub because of limited space here with the toilet. But this is a way that the client can get in and out of the tub without having to step in and out, again, for clients with those physical balance issues. And this is just an example to highlight the role of OT in increasing bathroom safety. So this is a collaboration between OT, ADS, and Building Management at Finch to improve safety for transfers and functional mobility in the Finch basement shower room. So before the OT assessment, there was a few issues in the bathroom. For example, near the toilet, the grab bar was actually placed backwards. This vertical part should be at the front because, we lean forward when we get off the toilet, and so a person would need to reach in front of them to grab hold of the grab bar. And the toilet paper dispenser was also blocking people from easily accessing the grab bar. So, after the recommendations were made by OT, this was modified for improved access and another grab bar was added. And then in the shower area, there were also issues like no grab bars, no seating, and a bath mat that wasn't optimal. It doesn't have really good grips. So after recommendations were made, grab bars were installed. There's now a shower chair. There's tread strips that don't require a bath mat, which can be moved around, but these are stuck to the floor. And then there was also a shower curtain added for privacy and dignity. Your role may also involve supporting clients to get in and out of bed safely by setting up and prompting clients to use adaptive devices. For example, if a client has a height adjustable bed, this feature can be used to ensure that the client's feet are flat on the floor, but at the same time, the bed is not too low, as this would require a lot of effort to get up and down. A client may also have bed rails or a transfer pole, such as the transfer pole in this image. In this case, you want to prompt a client to make use of the transfer pole in a safe manner. If a client has hemiplegia, that is paralysis or weakness on one side of the body, prompting would include ensuring that they're using their stronger side first. So for example, the woman in this photo might have hemiplegia on her left side, so we would prompt the client to reach for the transfer pole with their right hand. Next, you're going to be watching a video that demonstrates how to support a client using a wheelchair to set up for their bed transfer. Please take a moment to watch the video now.
During a stand pivot transfer, the wheelchair is placed at a slight angle to the transfer surface. The brakes are applied and the footplates are removed. The wheelchair user stands up as outlined previously. Once in standing, the wheelchair user takes small steps and pivots until their knees are touching the back of the bed. In this position, they reach back with their hands, bend at the hips, and lower themselves down until they feel the bed underneath them. From this position, the wheelchair user can lower themselves onto the bed. To transfer from the bed to chair, the same procedure is followed.
That video was great for demonstrating several key strategies for safe bed transfers. Number one was the angle and positioning of the wheelchair. So when you're setting up a client's wheelchair, keeping in mind to get close and be at a slight angle to the bed. The way that you angle the wheelchair depends on which side the client is stronger in. In the video, the gentleman's wheelchair was positioned so that his right side was closer to the bed. This would be appropriate for a client who has left-sided weakness and the right side of their body is stronger. Thus, they're going to lead with the right side first. Next, let's think about some other important features that were demonstrated. Number one, ensuring the brakes are on at all times before a client is about to move in or out of the chair. Next is communicating clearly. Ready, set, stand. That way both you and the client know what to expect and you're on the same page. Next is one of my favorite cues, which is ensuring a client knows when it's safe to sit. And they can do this by ensuring they feel the bed on the back of their knees before they start lowering down. Clients often find this very helpful, as some tend to struggle with sensory or depth perception. And so what you can do is either verbally tell them or lightly tap the back of their knee to draw their awareness to it. This prevents some clients from lowering down before it's safe and falling on the floor and missing the bed. Lastly, prompting clients to lower nice and slowly so they don't go down with a lot of momentum. Now, when it comes to car transfers, the most important thing to remember is to cue clients to use the most stable surface to help with their transfer. Clients are commonly reaching for the car door. It's just easily within reach. However, the door moves, can close on the client and cause injury. So as much as possible, we want to redirect clients to use the car frame, the seat, and their mobility devices as much as possible. We also want to think about how to make the transfer easier for the client. This can be done by maximizing legroom by moving the seat back before a client gets in. Lastly, if a client gets to their seat but is not in the best position to get their seatbelt on, you can verbally cue them to scooch their hips back into the seat to sit better. Now let's talk about the easiest strategies to get wheelchairs in and out of vehicles. Number one is removing as many parts as possible to lower the weight, size, and chance of damaging the device. So each chair might be a little different, but in general, the removable parts will be footrests, backrest, cushion, bag, and accessories. Once you remove these items and place them in the trunk, you can fold the wheelchair. The next thing to think about is proper body mechanics, bending at the knees and not twisting. These are essential to help prevent musculoskeletal disorders. Now, perhaps the hardest part of transferring wheelchairs is the lifting and getting them into the vehicle, but there is a strategy to reduce that strain, and it involves bringing the chair to the edge of the trunk and tipping it in. Using a blanket in the chair's vehicle to prevent scratches will be helpful here. And of course, having a second person assist you would make this all easier, but we know that's not always possible. So on the next slide, watch the video that demonstrates one person doing this transfer.
In this training video, you will learn how to support clients that use wheelchairs to safely transfer into Cheers vehicles. For a client with right-sided weakness or paralysis, how would you support with setup and queuing? Let's watch and then discuss. The wheelchair should be positioned at an angle close to the vehicle to minimize the distance that the client needs to transfer. Ensure the brakes are on and the seatbelt is undone before cueing the client to stand. Cue the client to reach their stronger arm to the handle above the seat or another stable surface on the vehicle. Then the client pivots using small steps and should be cued to touch the back of their knees to the seat before sitting. Finally, the client takes their position in the seat by lifting one leg into the vehicle at a time. A common way that clients tend to transfer into vehicles is by reaching for the door's interior handle, and although this might feel comfortable for the client, it could lead to falls or injury because the door moves shut. If clients absolutely must transfer this way, staff should guard the door at all times, but be cautious about your own safety. We do not recommend that clients transfer this way. Once your client is safely in the car, you'll need to place their wheelchair in the trunk. Let's look at how to do this more ergonomically. Every wheelchair is different, but generally you'll start by removing the cushion, then the footrests, and any other accessories before you can collapse the wheelchair. Ensure the brakes are on so the wheels do not spin around, and then back up the chair so the backrest is as close as possible to the trunk. Bending at the knees and keeping your back straight, lift the front of the wheelchair by holding on to a non-moving part and tilt it back onto the trunk. Finally, hold on to each wheel and swing the chair into the car, keeping it close to your body to avoid excess bending. To remove the wheelchair, simply reverse this process by first pulling it out closer to you, then grabbing both wheels, swinging the chair towards you, and leaning the back onto the trunk before lowering it down.
We hope you found the demonstration video useful to show efficient strategies to transport wheelchairs. If you do have questions, please bring them to the in-person skills portion, where we'll also have a chance to practice some skills. Now I'll turn it over to Cove to go into how to use wheelchairs.
Protect yourself and your long-term health by practicing safe body mechanics. Proper safe body mechanics include 1. Using a wide base of support, which means your feet are further apart and not close together. 2. Bending at the knees. 3. Keeping your back straight. And finally 4. Keeping your neck neutral. These core body mechanics make up the power stance, which is especially useful when you're handling larger equipment. For example, use the power stance when you are pushing a client in a wheelchair or commode and/or placing assistive devices inside the car trunk. When pushing a wheelchair, protect yourself by activating your core, straining your back, and keeping the wheelchair close to your body. When bending down, for example, to adjust footrests or put on a leg brace, protect yourself by coming at the wheelchair from the side, straightening your back, and bending at the knees. Crouch, kneel down, or sit on a chair or stool if available. Do not forget to communicate with your client to let them know what you're doing before you start. When pushing a client in a wheelchair on an incline, such as a ramp, use the following techniques to protect yourself and your client. Ensure client's seatbelt is fastened. When moving up a ramp, push up and forward with the wheelchair and have the client lean forward. Keep your body close to the wheelchair with your arms close to your body while maintaining a neutral back posture. Use the power stance and hold tightly onto the handles. When moving downhill or ramp, use a backwards motion instead. Keep yourself close to the wheelchair and activate your core. Use the power stance and hold on tightly to the handles, and then move slowly down the ramp. When maneuvering clients in wheelchairs outdoors, you may need to navigate curbs that are not accessible to wheelchair users. If you need to assist a client with navigating up a curb in their wheelchair safely, please do the following. Before you begin, ensure your client has their seatbelt on and always communicate with your client. Press your foot on the wheelchair frame bar, not the anti-tippers, push down on the handles, and gently tip the wheelchair backwards. Then push the wheelchair slightly forward so that the front wheels are on the curb. Then use the power stance to push the back wheels onto the curb. It is very important that you do not lift the wheelchair while pushing it up a curb. When you need to assist a client with navigating down a curb in their wheelchair safely, please do the following. Again, ensure client has their seatbelt on and always communicate with them. Proceed backwards with the wheelchair and have the back wheels meet the edge of the curb. Make sure you keep your back neutral, body close to the wheelchair, and arms close to your body. Then use the power stance and hold the handles tight. Then slowly pull down the wheelchair down the curb.
Let's talk about the importance of posture when it comes to functional mobility. Posture is essential for eating. Just take a look at these images on the right. The first one here shows the ideal posture. It's facilitated by having the setup support a good posture. So having a chair that is sturdy, not too cushioned, so the person's not sinking in, and having the table be at an appropriate height for the person and close enough. This facilitates nice 90-degree angles at the elbow, the hips, and the knees. Whereas in this bottom image, we have a person who's really sunken into their chair. The table is further away, causing them to reach. Maybe their head's going to tilt very far forward, and the table is at quite a high height as well. So we know that posture is important because it prevents choking by creating a clear airway. It also improves head control and jaw stability. Good posture also improves hand-mouth coordination, reduces messes, and if somebody's eating with others, it encourages communication and enjoyment at meal times. So overall, the essentials here are upright position, supportive seating, shouldn't be overly cushioned where they're sinking in. We want feet flat on the floor and well supported. We want to ensure the table is at an appropriate height for the person, perhaps depending on the client, some supervision around meal times to, cue for appropriate posture, and some cues to support slower eating to prevent choking as well. And posture is also essential for wheelchair users. Proper posture ensures that wheelchair users don't have to expend so much energy to propel their wheelchair, and it also decreases the risks of injury. So what we're looking for here again is these nice 90-degree angles. The feet are also supported. If the feet are not properly placed on the footrests, what we tend to see is clients sliding more forward and perhaps even out of their wheelchair. We also don't want to see the knees up too high, putting a lot of pressure on the lumbar, and we don't want to see clients slouch forward or to the sides. Again, that social aspect, right, of clients who have upright posture are more able to engage with people around them. So in your role, you might be providing verbal cues to a client that you notice they might be slouching or not in an upright position. Some helpful cues might be, look up, chest up, or whatever your client prefers and responds to best. Now in this section, we'll introduce mobility devices. We'll go more in depth during the in-person skills portion, so here are the fundamentals. There are two main types of canes: single point canes, which have one point in contact with the ground, and quad canes. They have this larger base of support with 4 contact points. So in general, canes are prescribed to individuals who need some balance support, but they can still mobilize. So when it comes to your role, we're looking out again for posture. If you notice clients are forward leaning, can you cue them to stand upright? Next is monitoring the condition of the cane, looking out if the tip is really worn out, the handle is falling apart. If you notice lots of rust, it might be time to consider replacing the cane. Next, when we think back to those cognitive and behavioral aspects of brain injury, looking out for how a client is using the cane. The main thing we see is just clients forgetting their canes. So, as we're moving from program to program, leaving a cane behind, or when the cane is there, not reliably using it. In addition to potentially unsafe use, like swinging the cane around or touching other people with it. These are all areas of opportunity for us to use those cognitive compensatory strategies. And some good to know features about canes is that in the winter, there are ice tips for the bottom that can provide more traction. Some canes are collapsible, and some canes also have wristbands so they can be carried around easier. Next are walkers. So walkers are prescribed to people who need more support than what a cane can provide. There's 2 main types of walkers. First is a 2-wheeled walker. This has 2 wheels in the front. There's no brakes. It's a pretty simple frame build. This is good for clients who just need to walk shorter distances. They might not be ready for a rollator walker. These might be clients who, they've had a recent history of falls. They've recently come out of the hospital. 4-wheeled walkers or rollator walkers, on the other hand, they have 4 wheels, they have brakes, a seat, a backrest, and certain accessories like a basket or a bag. These provide balance support, but they're for clients who can walk longer distances. Perhaps they need to take some breaks, so that's where the seat comes in. These are great for outdoor mobility as well. Sometimes the wheels can be bigger depending on if the client is going to use them outdoors a lot. So how do we want to support clients with walkers? Again, first, this principle of posture applies. So if there's slouching happening, we want to prompt clients and also take a look at the height of the walker to ensure it's still appropriate for them. You might also notice that a client is not centered within their walker. So perhaps the walker is far out in front of them. Their arms are outstretched. Well, we want the walker nice and close. Next is the condition. So if either brake is not working, that needs to be repaired. It's a priority. The other thing to look for is jammed wheels. Sometimes they can become jammed from debris. Lastly is how a client is using the walker. Something we commonly see is clients using the walker quite quickly and it's almost running away from them. So in that case, something that could potentially be done is having slow down brakes, which just has the wheels move a bit slower. We also see clients forgetting to apply the brakes. This is very common, so being there to help with cueing and those reminders and creating a habit of it as much as possible. And lastly, clients might bump into things with their walkers. So when you're helping clients navigate in the community or at a program, looking out for things that are in the way, like chairs or people, and helping them navigate that.
Now let's review the 4 types of wheelchairs. For most of these wheelchairs, they must be prescribed and custom fit to the client by a qualified health professional such as an occupational therapist or physical therapist. First, let's go over the transport wheelchair. Like the name suggests, the transport wheelchair is meant for short distance use, and its general purpose is to transfer a client from point A to point B. It's commonly found in hospital settings and is lightweight and has basic seating, backrest, and footrest. A manual wheelchair, on the other hand, is the most commonly prescribed wheelchair for Cheers clients. These wheelchairs are highly customizable with larger back wheels for self-propelling manually, custom seating, and custom backrest and footrest. Next is the tilt or recline wheelchair. Like the name suggests, these wheelchairs have a tilt or recline feature which is operated by staff or a caregiver to tilt a client in the wheelchair and provide them with pressure relief throughout the day and to prevent pressure sores from developing. A tilt or recline wheelchair is more commonly found in long-term care homes. Finally, a power wheelchair is a mobility device that is operated and controlled by a client, usually with a custom control option such as a joystick that the client can access. Unlike the previous wheelchairs, its wheels are motorized. The wheelchair features such as the backrest, seating, and footrests are also highly customizable. Clients who use the power wheelchair must also have the cognitive ability to control it safely in their environments. Here are a few general tips for clients in wheelchairs. First, ensure brakes are on before all transfers. Second, anti-tippers are installed properly and set in a downward position. Then ensure seatbelts are on to provide better positioning support for clients. Be also mindful of settings for armrests, footrests, and any other angles on the wheelchair. There are a couple of funding resources for assistive devices. The first is the Assistive Devices Program, or ADP for short, which is a government-funded subsidy for clients who are in need of mobility devices. ADP can help pay up to 75% of the cost of equipment if approved. Clients must also be assessed and approved by an ADP authorizer who can prescribe mobility devices. Clients are eligible for a new mobility device under ADP every 5 years and every 2 years for new seating and positioning on their mobility device. If a client's mobility device is no longer suitable to the client, such as a significant change in their mobility status, then they may be eligible for new equipment earlier than 5 years. The Ontario Disability Support Program, or ODSP, is another program that can assist eligible clients with funding assistive devices. In this section, we will review falls. Falls are defined as an event where a person inadvertently comes to rest on the floor or on a lower level due to a loss of balance and inability to recover their balance. It's important to note that falls do not only include the client falling onto the ground. Falls can also include falling on a lower level, such as falling onto a bed or falling onto a chair. Let's consider the risk factors that contribute to falls. On this slide, fall risk factors are organized into 3 categories: person-related risk factors, environmental risk factors, and task-related risk factors. If you have a client who has fallen, you can gather information about the person's risk factors, such as visual impairment and impaired balance, that can contribute to their fall. You can also take into consideration their environment and assess if poor lighting and clutter on the floor were contributing risk factors at the time of their fall. Finally, consider the task your client was engaging in at the time of the fall. Was the task too complex for your client? And did they need each step broken down and prompting to complete the task? Understanding the risk factors as they relate to the client, environment, and task can help with gathering information and providing supportive evidence to properly assess and plan fall interventions for clients. The following are examples of interventions related to fall prevention. For example, if a client you know has a vision impairment and balance issues that contribute to their falls, then annual vision testing and an exercise support program can lead to your client wearing appropriate eyewear and improved strength and balance. Also, you can refer to an occupational therapist to conduct an environmental assessment and provide recommendations, such as reducing clutter and tripping hazards in the client's environment. Finally, creating and following an individualized support procedure can help clients break down complex tasks and complete them safely with staff support and prompting. It is very important that you do not try to catch a falling client. When you try to catch a falling client, you could put yourself and the client at risk of injury. For example, you can injure your back or disrupt the client's falling response, leading to client injuries such as shoulder dislocation and shoulder subluxation. Instead, what we can do is focus on preventing falls by establishing routines, providing supervision, and ensuring proper footwear is worn. We can also set up the environment for clients by ensuring grab bars are in place, and placing wheelchairs behind clients, and applying brakes during transfers. Also, consider the type of falls. Do clients have frequent sudden drop falls or slow falls? For example, sudden drop falls may happen with clients who are prone to seizures, so take a different approach than clients who have controlled slow falls due to hemiparesis or weakness on one side. The safe landing response is the body's natural response to protecting oneself during a fall, such as bending at the arms and knees, protecting one's head, and catching oneself with an outstretched arm. However, for our clients who have brain injuries, their safe landing response is already impaired or delayed. So when you try to catch a falling person, you actually interrupt their safe landing response, and this can further impair their protective actions during a fall and lead to serious injury.
So keeping in mind that we do not catch falling clients, let's look at how we do respond to falls. The overall message to begin with is that we expect falls to happen. Just statistically, falls are the leading cause of injury among older Canadians, and when it comes to adults with head injuries, it's found that they're up to 2 times more likely to experience a fall. So when falls happen, what do we do about it? If a client has fallen and they have an individualized support procedure related to fall prevention and response, refer back to that procedure to guide your next steps. In general, the first thing you want to do is assess for injuries. That will determine your next step. If a client is not injured, this is where your communication comes in, as you'll be coaching the client to get to their knees and then to a chair if possible. Otherwise, further steps might need to be taken, like calling 911 and having EMS come to support the client. But again, this should be outlined in the client's individual support procedure so that you'll know what to do. In the next slide, you're going to watch a demonstration video that lays out these steps where the overall message is, no lifting and communication and support in the environment being the key. After you watch the video, think back to a situation where you responded to a client fall. What do you think went well, and what could be improved for next time?
To help a fallen person, the most common error is attempting to lift somebody that has fallen on the ground yourself. Trying to lift a fallen person poses too much risk to both the fallen person and to you. What you should do is, after confirming the surroundings are safe and that the fallen person is fully conscious and has not hurt themselves, place a stable chair close to the person, about a foot away from their head. Then, coach the fallen person, using words, to shift onto their hands and knees in a crawling position. Once in the crawling position, coach them to position their hands onto the chair seat. Then, standing behind the chair to stabilize it, tell the fallen person to use the chair to help boost themselves up so that they can sit on the chair. Once the person is seated, then you can assist them safely. If the person is injured, call for emergency services.
If a client has fallen and they have weakness or paralysis on one side of their body, the same principle applies as when we were talking about setting up transfers. We want to help cue the client to use the stronger side of their body to push up first into a seated position. Then we help the client use stable objects in the environment like a chair in order to get up. So throughout this process, our involvement involves verbal and physical cueing. Physical cueing could look like lightly tapping the area that the client needs to focus on. For example, the specific arm or knee that they should be moving at the time. To reiterate, do not lift a client up from a fall. This could lead to injury for you and for the client. Instead, after your assessment, if you've determined the client is not injured, brace a chair and verbally coach the client to get up to the chair. If there's any possibility the client has been injured, do not move them and instead call for medical attention. When falls happen, a fall incident report should be completed that captures when the fall happened, where it happened, what activity the client was doing at the time, the type of fall, whether it was witnessed or unwitnessed, whether an injury was sustained, which is a really important piece to capture, and whether the client was using an assistive device at the time. As part of the CHEERS Client Safety and Wellness Committee and the Fall Prevention Program, we monitor the fall report data for trends. We look at markers like total falls, individual client fallers, falls by program, and injury data to gain more insight into why, when, and where falls are happening, and this helps to guide our response. After a fall has happened, particularly if injury is involved, you might consult with a member of the clinical team, like OTs or BTs, for an assessment along with recommendations. OTs might make recommendations in one of several areas, for example, addressing personal risk factors, like generating a balance and strength or return to walking program for the client, and referrals to external care providers. We might also make recommendations to modify the task if a particular task was being done at the time a fall happened. For example, if a client was in their room reaching for something at the time of the fall, we might look at how to reorganize the way the task is done so they no longer have to reach in that way. And lastly are the environmental supports. For example, we might prescribe adaptive equipment, reposition existing equipment, or temporarily increase staff supervision and support for that client. Behavioral therapists might generate behavioral plans, monitor progress, and together we can provide some coaching to staff on the best ways to implement these recommendations for the client. As a committee, we've noticed that the client incident reports might not be organized in an optimal way for accurate completion. This could potentially explain a jump in the number of falls, and we want to ensure that the client incident reports are accurately capturing what's happening. So we've made recommendations as a committee to improve incident report templates by providing clear definitions of what an injury is, for example, and providing staff training on best ways to complete an incident report. Based on the data from 2023 and 2024, we saw that most falls tended to occur earlier in the day, during the morning and afternoon. It comes as no surprise that the most falls tend to be reported in the residences, particularly the residences with the higher numbers of clients, particularly Aldebrain and St. George's. We also saw an increase in reported falls from 2024 compared to 2023. This could be potentially explained by clients aging and comorbid health conditions occurring. It could also be related to the accuracy with which reports are being completed or how often reports are being completed as well. And falls do also occur in the other programs too. The majority of falls happen in the bedroom or bathroom. This is when clients tend to be by themselves and spend a bit of their time doing more of those transfers that we talked about earlier. Other common locations include outdoors and in the community, in living or dining areas, and a smaller proportion in the kitchen. The majority happening in the bedroom and bathroom is in line with national falls data. It is expected that this is where falls are going to occur, if they will occur. And so how can we best support clients, especially in those environments? In terms of what clients are doing when they fall, the majority of falls tended to occur when clients were walking or transferring. Again, we're talking about transfers and functional mobility for a reason. Clients often need support in these areas to go about their daily lives. Otherwise, a lot of falls are unwitnessed, and so the circumstances about why the fall occurred are not known, but in some of the cases, reaching, toileting, or showering were involved. So the majority of reported falls were unwitnessed, and this comes as no surprise if the majority of falls are happening where clients tend to be by themselves, in the bathroom and the bedroom. In many cases, staff discovered clients had fallen after hearing a noise or checking in on the clients. Now, thankfully, the majority of falls reported did not result in injuries that required medical attention, but we still want to lower the trend. In fact, some of the injuries reported as part of this were quite minor, including bruises and redness. And so, again, we're looking at ways to best capture the different types of injuries that occur as well. So far, we discussed the essential principles of supporting clients with their transfers, mobility devices, and overall mobility. Let's wrap things up by thinking about the benefits of functional mobility and supporting clients out in the community. I hope by now the importance of your role in supporting clients to live safe, meaningful lives is quite clear. There's a principle in functional mobility called use it or lose it, particularly in regards to muscle strength and cardiovascular endurance. The less active clients are, the less active they're likely to be, and the more injuries they'll be prone to. So functional mobility, helping clients move around in their daily life, increases their opportunities for social interaction, it improves mood, and overall quality of life. Importantly, staying active decreases boredom, mortality, and fall risk. So be proud of the work you do. It's really important in order to help clients do the things they want and need to do and live a meaningful life. Engaging in exercise routines is a fantastic way to capitalize on functional mobility and improve overall health, but it's not the only opportunity. By supporting clients to engage in day-to-day activities and programs, we're helping them to maintain function in a really applied, meaningful way. So thinking about how can we encourage more physical engagement during the course of a client's existing daily routine. Thinking about maintenance being an achievement too. So perhaps, increasing physical strength might not be a realistic goal for everyone, given their preferences and what they have access to, but maintaining their strength and focusing on not deconditioning can also be a meaningful goal. We can assess progress by looking at how engaged clients are in programs, by observing them when they are engaging, and by the client's own report of how they feel and how satisfied they are. As we mentioned earlier, not only can factors related to brain injury impact a client's functional mobility, but the environments around us and how accessible and supportive they are impactful as well. And so if you're supporting clients to go out into the community, some things you can do are call ahead and ask about barrier-free entrances, accessible washrooms, and quiet spaces. There are also a number of websites online that provide crowdsourced information about these aspects of locations, and you can also go on Google Maps and look for updated images as well. This wraps up the virtual portion of the Supporting Functional Mobility and Safe Transfers training. We hope throughout the training you really got to understand the expectations of the CF and RF role when it comes to this area, as well as how OTs can support you as well. We took a look at the different policies which are on SharePoint, both the policies and guidelines, so feel free to refer back to those, as well as clients' individual support procedures. We also really emphasize the importance of protecting your own body as well, using proper body mechanics and strategies that prevent you from the risk of developing musculoskeletal disorders. Client safety was also another really important theme of this training, and so we have specific policies and procedures in place about how we support clients' mobility and transfers that reduces their risk of injury as well. In the in-person skills portion, we will carry on with each of these sections in terms of actually interacting with mobility devices and practicing setting up transfers. So we hope to see you there. Thanks for your attention to the training. At this point, you can complete the post-knowledge check. Feel free to reach out to the OTs with any questions, and we'll see you at an upcoming in-person session.